see you.
Okay, we can now I can see we have the first author, Professor Fazlyab, and also the appraiser.
I'm here.
Good to see you. How are you?
I'm okay.
So first of all, help me and let me know how can I pronounce your name?
Burçin.
Burçin, that's great. That's great.
Perfect.
We have Professor Bulkin with us. Dr. Bulkin is a member of Bahçeşehir University. This time we have a change actually. The change is actually based on, hello?
Hello.
It seems that I was disconnected, so let's go back. I'm in again. Okay, sorry about that. That was a technical issue, I believe. Do I have my voice? Do you have my voice, Burçin?
Yeah, we can hear you.
Good. So I'm back. All right, so today we are going actually to discuss another article, but there is a change in the plan. The change is actually a colleague from Bahçeşehir University from Turkey, Istanbul. She's going to present the article, which is published by a group under the leadership of Professor Mahta Fazlyab. We have Mahta with us. Mahta, please go ahead and introduce yourself, please. We know you very well from the previous sessions, but it's good actually to have your introduction first.
Hello, everybody. I hope you have a good time. Thank you, Dr. Nekufar, for having me with you. And special thanks to dear Burçin, who is going to present our article. I hope you have a good time, and I'm at your service, whatever you need.
Good to hear that. And before we go further, we have actually Ilke with us, and Ilke is the secretary of the educational committee of APEC. So I'm going to ask Professor Özgür Ilke Ulusoy to say something before we officially start. Ilke, please.
Hi everyone, it's nice to see you. Greetings from Turkey, and it will be a great discussion as always, and good luck to speakers, to the great speakers, experienced speakers. Hello, Burçin.
Hello, my dear professor. Thank you so much.
Okay, and we have Professor Beybara Kayahan with us, the ex-president of APEC, and whenever possible, we have him and we have his support, and we have also Professor Viresh Chopra. Viresh Chopra, please, you go ahead and say hello to everybody, and then Professor Beybara. Viresh, please.
Hi, Prof. Nekufar, how are you, sir?
Thank you very much. Thanks for being with us. Also, we always have your support. Thank you very much. Please go ahead.
Always. Hi, Oscar. Hi, Pomegranate. Looking forward to a great presentation here. Good to see smiling faces and known faces after a long time.
Nice to see you, Viresh. Dear Viresh. Nice to see you.
Yes.
Okay, Professor Beybara, please go ahead.
Hello. How are you?
We missed you. Beybara, we missed you in previous sessions. Thank you very much for joining us.
I didn't see him. Hi, Dr. Beybara.
Hi, Viresh. How are you? Hi, how are you?
Fine, good.
I missed you too. We are still going to hard days, but we are here now. And I'd like to thank you, Mohammed. Thank you once again for this perfect organization. You are always going on your way, and I'd like to thank you very much.
Thank you very much. And Professor Zargar, do you want to have a word before we officially start, please? Go ahead.
Hi, everybody. I'm glad to see you. Congratulations for this presentation. nothing to say. Thank you.
Okay, good. Okay, everybody, we are going now to officially start this session. And we should say thank you very much to our sponsor, because as you know, sometimes for the platform and for other costs, we need a sponsorship of different companies, and Woodpecker is one of the very generous ones that they support APEC and TUMS and all of these congress around the world. So my colleague Zohre is going actually to start by showing you a video clip from our sponsor, and then we will officially ask Burçin to give us a presentation about the article. So this time we don't have any postgraduate student to appraise the first author. So the job of Mahta is very, very difficult, I believe. So we put Mahta in a very hot chair. Although Mahta is my fellow Iranian, I don't have any conflict of interest, and I will kill everybody. And I don't mind actually to put Mahta in very difficult situation as well. Mahta, be ready. Okay, Zohre, if you are ready, please show us the video from our sponsor. Okay, Burçin, you can share your presentation and start talking about the publication. Please, go ahead.
Okay, thank you. Now I'm sharing with you. Yes, could you see my screen?
Yes,
now?
yes, very well,
Yes.
very well.
Yes. Okay, okay. I'm Assistant Professor Burçin Arıcan from Bahçeşehir University, Istanbul, Turkey. I am the appraiser of this session today, and we will discuss the article entitled Effect of Low-Level Laser Therapy on Postoperative Pain After Single Visit Root Canal Retreatment of Mandibular Molars, a randomized controlled clinical trial. When post-treatment endodontic disease emerges or persists following root canal treatment, root canal retreatment is recommended. So the main cause of these treatment failures could be primary infections or secondary invading microorganisms, and the success rate could be changed from 77 to 89%. And the main complications of retreatment is the postoperative pain, which is that means discomfort, which is an unknown, undesirable situation. And according to a systematic review, a current systematic review, a frequency of postoperative pain could change from 3% to 55, 58%. Okay. So it's an uncommon situation. So what are the strategies to control this postoperative endodontic pain? We have several approaches. These are pharmaceutical approach, antihistaminics, steroidal and non-steroidal anti-inflammatory drugs, narcotics, intracanal medicaments, administration of long-lasting anesthetics, non-pharmaceutical strategies, intracanal laser irradiation, and the last one is low-level laser therapy. But what is the low-level laser? Class 3 lasers with an output power of less than 0.5 watts are classified as cold lasers, or in other words, low-level lasers. These are non-invasive and do not create heat, sound, or vibration during treatment. What about the history? The history of applying LLLT goes back to pain relief in orthodontic patients undergoing fixed appliance therapy. It was 2006. Since then, 2006, it has been used for analgesia, modulation of inflammation, regeneration of cells and tissues. LLLT at the tissue level upregulates the function of fibroblasts, accelerates connective tissue repair, and has anti-inflammatory effects in the absence of significant thermal change. And also, it elicited biomodulatory effects that delayed pain and reduced pain severity and duration in patients undergoing fixed orthodontic treatments. So what about in endodontics? There are several several articles in the literatures. One of them belongs to Doğanay Yıldız and Hakan Aslan, and they evaluated the effect of low-level laser therapy on postoperative pain in molars with symptomatic apical periodontitis, and they reported that it has a positive effect in root canal treatment in teeth with symptomatic apical periodontitis. And also another study belongs to Nazari et al. They also evaluated the effect of LLLT with different locations of irradiation on postoperative endodontic pain, but in this case with symptomatic irreversible pulpitis, and they reported positive results. Another study belongs to Chrysler et al., and they reported that LLLT has a beneficial for the reduction of postoperative pain after endodontic surgery. And also, Nabi used LLLT with the combination of ibuprofen, and they reported that this combination can effectively reduce the post-op endodontic pain in single-visit endodontics. But what about the retreatment cases? There is only 2 articles in the literature about retreatment procedures. One of them belongs to Ehsan et al., the other one belongs to Esnaashari et al. Ehsan et al. Evaluated the effect of low-level laser therapy on postoperative pain after root canal retreatment, and they applied...
Gulçin, may I ask you to speak a bit slower, please? Because you speak very quickly and maybe we cannot digest and follow you. Thank you.
Okay. Aslan et al. Evaluated the effect of LLLT therapy on postoperative pain after root canal retreatment, and they applied double sessions, double visits, and they used calcium hydroxide, and they reported positive results about the LLLT. On the other hand, Esnaashari et al. Reported the reverse. They reported that LLLT has a minimal effect on reducing the postoperative pain. So the net effect of LLLT on retreatment cases is uncommon, is not clear. So the aim of the authors was to compare the effect of LLLT on postoperative pain after single visit root canal retreatment on mandibular molars. The null hypothesis of them was there is no difference in postoperative pain after single visit root canal retreatment between the LLLT and sham groups. So their material and methods.
Okay, before you go further, can I stop you, Gulçin? Because you already mentioned something about the post-operative pain and compare something between primary endodontic treatment and secondary endodontic treatment. I believe the first question that we can ask from you even, or from the author, is it really an important issue when we speak about, sorry, something happened. Wait a minute. Okay, sorry about that. I'm speaking about the importance of post-operative pain in endodontics. As a practitioner, I don't mind speaking about the post-operative pain. And I think, to be honest, I think post-operative pain is not a very big issue for me. I can manage that by a lot of strategy. Is it really a big issue or not in clinical endodontics? I think it is going to be a big question. So first of all, I want to ask it from you, and I want to have the idea from others as well as clinicians, especially the clinicians that they work in the clinical area. Is really post-operative pain a big issue for them or not, at least in primary endodontics? However, maybe you may say that in secondary endodontics, in retreatment, that can be an issue. Then we will discuss that. Okay, let's go for primary and the importance of post-operative pain. Is it really important or not? Burçin, what do you think personally?
For me, it's not a big issue for me too, because we have several equipments, several acetaminophen, ibuprofen, we have several non-steroidal anti-inflammatories, and we can control it. So it's not a big issue, especially for primary infections, but sometimes it may affect negatively the trust of your patients to you. So it may be a problem for retreatment cases. So we should focus on retreatment cases, not the primary infections. That's for me.
Okay, what do you think? Is it really important for you? Viraj, can you hear me?
Oh, okay, me. Sorry, I didn't hear.
What do you think? Is it really the post-operative pain? Is it a big issue? Although Burçin say that they use actually post-operative analgesic. Okay, if it is the case, then that means it is important for them to prescribe that. But my question is about the importance of post-operative pain in general in endodontics. Is it a big issue?
I really do not think so, that it's a big issue, because when we do, there is a bit of gap between what we read in the books and what we do in clinical practice. I have seen that when we are dealing with the patient, and obviously when we are going to start the root canal treatment, we basically tell the patient that there might be a bit of pain after you might be feeling a bit of discomfort after the visit or after the obturation visit or the cleaning shaping visit, depending upon the case how we are dealing with. So like Burçin said, regarding the trust of the patient, probably this point covers the trust of the patient. In retreatment cases, however, definitely, I don't think post-operative pain is an issue, but I feel flare-up is a bigger issue in cases with, retreatment, or you can say chronic infections. Flare-up is a much bigger issue, which breaks the trust of the patient there when suddenly swelling comes, because patient thinks that swelling is because of doctor has done something or something like that, different psyche of the patient. So I don't think so post-operative pain is a bigger issue. I feel in retreatment cases or chronic infection, flare-up is a much bigger issue.
Okay, so you in that case, I think I'll give the question to Mahta, because the base of this study is actually produced. So they build up this study on the importance of the post-operative pain and flare-up, obviously, as you mentioned. So Mahta, can you tell us why you decide to do this study? I mean, the aim of this study, is it a big issue? Is it really a big question for us or not?
Professor Nekoufar, I do believe that we are speaking in a group of endodontists, and these things are a routine for us, that we face patients that are experiencing pain. This pain may be nothing for the clinician because we know how to manage it, but we must put ourselves in patients' shoes. We must see from their side. Their tooth is the earth and heaven for them, especially when they have paid for the treatment. They're leaving the office. They expect to have a pain-free experience after the operation. And I do believe that, especially after retreatment, or even after treatment cases, even after endodontic treatment of a vital teeth, I do believe that the patient may lose the trust. And the clinician is the one who loses something, may lose the patient, because the patient starts seeking for other clinicians just to ask them, why is this happening to me? Is there any problem with the previous treatment? Is there any remaining tissue in my tooth? We have heard these questions from our own patients when they are coming to us from other colleagues. So I do believe that it is important, not as much as importance of other issues, but it has its own weight, I believe.
We have Talal with us. Talal, hello, how are you? Thank you very much for joining us. We start actually our discussion based on the importance of, I will say that post-operative flare-up from now, as Viresh suggested, rather than post-operative pain. And I just asked Mahta, the first author, to explain for me why she decided to do such a study if the post-operative pain is not a big issue for us as endodontists or even for dentists. Is it a big issue, do you think, Talal? Talal, you can go ahead.
Yes. Thank you very much. Always glad to be with you, my friend. I believe one of the most important things that make people visit the dental office is the pain. And they are really concerned about if they're gonna have any pain later on. So it's very important to focus on this point and to find solutions to minimize the post-operative pain, or as Viresh wants to say, the flare-up, minimize the flare-up, the potential, by doing a lot of mechanical instrumentation to prevent the pushing of the debris outside, and also finding the laser, soft laser. I'm interested also to hear about this article and to find other solutions to minimize. I believe it's very important. Yes, my friend.
Okay, so the answer to my question based on some idea that I tried actually to collect from my colleagues is, yes, the most important pain is important if we think from the point of view of our patient. As Talal mentioned, many patients came to our office and they are worried about producing post-operative pain after endodontic treatment. Okay, I agree and I accept that. And the second question coming in that point about what type of cases that we should select when we want to run and design such a study, because Burçin is going to give us the methodology of this study to tell us why they decide this or why they decide that. An introduction, we mentioned something about the comparing retreatment cases with primary treatment cases and the incidence of post-operative pain in them. Mahta, do you want to add something about this concern of myself, comparing primary and secondary treatment with each other in terms of possibility having post-operative pain?
I think I must just add something, that the cases with the most numbers of flare-up are retreatment cases. So I think doing such study on retreatment seems necessary for us. But I will listen to other colleagues what they say about this.
Okay, Burçin, you go ahead.
Okay. Now,
so do you think the idea of selecting secondary treatment rather than primary treatment has some backbone to make this study more powerful or not? Burçin, can you hear me?
Do you asking me? Okay. Okay.
Yeah, my question is why they decide actually to do this study on post-operative pain on retreatment cases rather than primary cases?
Because there are very few literatures, there are few articles in the literature about post-treatment cases. So the net effect of LLT is not clear. So they are trying to find the effects of LLT, especially on post-retreatment cases, not the primary ones. Generally,
okay, because they are expecting to have more pain, yes. Obviously more post-operative pain in secondary treatment cases comparing to primary one.
Yes, yes, yes.
Okay, let's go ahead.
The authors follow the pre-rate guideline 2020, and the ethical committee, the study was approved by the local ethical committee, and informed all the patients was signed a fully informed consent. And the study was conducted in the Department of Endodontics, Faculty of Dentistry, Tehran Medical Sciences, Islamic Azad University in Iran, from March 2019 to March 2020. They have some inclusion and exclusion criteria. According to the authors, patients in good health as determined by their medical history and verbal questioning were included. Root canal retreatment on symptomatic first and second mandibular molars were used. Mandibular molars with previous root canal treatment with a pi index score of 2, in other words, indicating small change in bone structure, and pi index score of 3, change in bone structure with mineral loss, were included in the study. Patients were asked to report their previous percussion pain and spontaneous pain using a visual analog scale on 170 millimeter, and those who had spontaneous pain and percussion pain less than 56 millimeter was were included. On the other hand, periodontal probing greater than 3 millimeter and the patients who had swelling, sinus tract, and palpation sensitivity were excluded. Actually, I have several questions about the methodology. Should I ask it now or at the end?
Yes, go ahead, go ahead. I have a lot of questions as well.
Yes.
Virtue, you can shoot at me, I'm here.
No, I'm not shooting. Actually, well, what about the periapical pathology? Is there any periapical pathology there? What about the lip numbness? How can you understand about your anesthesia? What about the patients who had taken analgesics before your...
Burçin, let's do it one by one. Let's do it one by one.
I have a list here.
Okay, one by one.
Okay, then, okay, start with, what about the periapical pathology of the patients? I'm wondering about it.
Yeah, that was my question as well, because they mentioned that the PAI score was 2. That means that almost there isn't any pathology. Why, Mahta, you choose these cases rather than cases with large pathology?
The truth is that I just wanted to follow the exact methodology done by Arslan et al. Because when I read the article by Arslan, the first question that came to my mind was that I have to just mention it before anything, that they just conducted their study exactly the same way. Actually, we followed their methodology, but the difference was that they just did this just double visit treatment, and they used calcium hydroxide as the inter-appointment medicament. The question that came to my mind was that maybe calcium hydroxide was effective in reducing pain or had some effect on post-operative pain. So I just wanted to take out calcium hydroxide from the study, and we did exactly the same thing as they did, just to compare the results with them. They did the study on the cases with periapical indices of 1 and 3. I believe that this could pave the way for other studies, other future studies. You could do such thing on exactly just with the same design on cases with existing, actually existing periapical lucencies, and just see the results. I don't want to spoil the case, but I am conducting other studies on the same things. There are a series of studies. This was the first one. Second and third one are on the way for being just written as the article. I don't know if it could help, but we wanted just to follow the methodology by Arslan et al. Burçin.
Okay, thank you.
Okay, that makes sense. Burçin, go to the next one.
The next one is, what about the treatment time? What about the treatment?
What do you mean? What do you mean by the treatment time?
The treatment time.
The duration of the treatment matter. For example, if a case is because we know that when speaking about the secondary treatment, they are not very similar to each other. Yeah. So if a case is very difficult and you have spent a long time or you use different techniques and you may push more debris outside, as Talal mentioned, you may create more pain. So if you spend, for example, 2 hours comparing to 1.5 or comparing to 1 hour for the treatment, then it may have some effect. Have you controlled that? Am I right, Burçin? This is the question?
Yes, definitely right.
Okay, good. Mahta.
For treatment duration, we wanted to do the treatment in one standard treatment session in any dental office. For example, it couldn't take longer than 2 hours, maximum 2 hours. If it was going to take longer than that, or the clinician had to just put the calcium hydroxide medicament inside the canal and they leave the rest of the treatment for next session, the patient would be excluded. This case didn't happen for us. This actually didn't happen, so we didn't report this. But for other criteria that you said, such as just extruding a debris or etc., we just randomly just distributed the patients. This could happen to anyone. This is my explanation. It could be the case for any of the groups. So it couldn't just, I think it couldn't have any effect on the results.
Okay. I have another question about the initial position of this retreated tooth. Is there any complication with them? I mean, a broken instrument and a ledge, any complication at the beginning?
We didn't have anything like that. Actually, cases with any obstruction that from the radiography, we thought that if they would be hard, they would be they wouldn't be a standard retreatment. They were excluded. Actually, they were not included to be excluded later.
Okay. Well, what about the patients who had taken analgesics before the treatments? Did you standardize them?
We didn't just include the patients who took analgesics. I think they had low pain scores, less than 50 millimeters on VAS, so they wouldn't normally take any analgesics. But if they did, we would exclude them.
Yeah, it was to mention that. It was to mention that at least in your future publication, it was to mention that if patient use any analgesic, because it has one of the co-founders that may change the results as well.
I think I'm just writing everything that Burçin is saying or other colleagues. I'm just writing them down because I believe that future studies are complemented by the previous ones. And the comments that she's telling me are very great. I will have just in my mind for the future studies. And
but obviously your explanation about your cases that they don't have any pain before you start your treatment, that will give this information that they might not use any painkiller as well, but good to emphasize that. Okay, Burçin, carry on.
Okay, I have another question, Dr. Nekopar.
Yes, go ahead.
What about the anesthesia? How did you understand that you get a correct anesthesia in your dental chair? Because it's also an important factor for postoperative pain. How did you check it?
Like any other standard criteria, we had the numbness of lips and the tongue, and we did not do the electrical testing, but the cold test after 15 minutes.
Okay.
If the patient was not responsive on the adjacent teeth, we understood that the anesthesia was deep enough to start the procedure.
Okay.
Burçin, I think these comments are really worth mentioning, in the article. Thank you.
Thank you so much. Now I'm going. Are you
yes, okay? Go further, please.
Okay, the authors also detected the sample size based on Arslan et al. Study, and they said that 18 for each group are enough for the sample size calculation. So what about
Burçin, can you go back to the previous slide, please?
Okay, yes.
It seems to me the name of the first author of this article that Mahta mentioned that they follow the methodology is from Turkey as well. Do you know this guy?
Yeah, I know Hakan Aslan. We know him.
Okay, so do you have any idea about the quality of their study or anything about that? And what do you know the affiliation? Which university Arsalan is working in that?
I think he is now in Sağlık Bilimleri University in Istanbul. He is good. He's a good academician. I'm sure he did perfect jobs.
Okay, great.
Great.
Thank you.
I know it. And randomization. The randomization was applied with www.random.org, and the retreatment procedure, laser irradiation in test and sham groups, post-treatment patient follow-up, and data analysis and interpretation. All these factors were followed by different researchers. So this is totally a blind study. What about the root canal retreatment procedure? A single visit root canal treatment was planned. The patient's demographic data and initial WAS scores for pain and perfusion was recorded. Local anesthesia was applied following the rubber dam application. After the access cavity preparation, the authors used the raised retreatment system with X-Smart rotary motors. They used DR1 and DR2 to remove the root filling material. And then the canals were negotiated to the apical foramen by using 15K file, and working length determined by using electronic apex locator and also controlled with periapical radiograph. During these procedures, no solvent was used. A size 13 hexastrom file was used with a filling motion to remove remnants of the root filling. Root canal preparation was continued until no gutta-percha was observed on the instrument. And for the shaping, they used raised rotary instrument. For mesial canals, they used 35 to 0.04 taper. And for distal root canals, they used 40 to 0.04 taper. For the final irrigation, they used needle irrigation. 5 milliliter of 5.25% sodium hypochlorite was used for 1 minute, followed by 5 milliliter of distilled water and then 2 milliliter of 17% EDTA for 1 minute. Then root canals were derived with paper points and filled using the lateral compaction of master and accessory gutta-percha cones and ash plus sealer. And then the access cavity was temporarily filled with cavit, and the final periapical radiograph was taken to confirm the quality of the root canal treatment. Then the patients were randomly divided into 2 groups. The first group was LLT group. Low-level laser was performed using a 980 nanometer diode laser set at 6.789 watt per centimeter square energy density, 0.5 watt power, and a tip diameter of 10 millimeter for 15 seconds. Then it was irradiated to soft tissue covering the mesial and distal apices of the tooth from the buccal side, with the tip of the laser handpiece held at a distance of approximately 10 millimeter from the mucosa. In Shan group, it's a kind of placebo group. They use the laser handpiece. They positioned the handpiece, but they do not activate it. I have another question here. Why didn't you apply these LLT for 15 seconds? Generally, I looked to other studies, it's more than 30. It's not only one time. They use several times, 2 or 3. Some use 30 seconds, some use 80 seconds. And generally, this 980 nanometer diode laser is a little bit higher than the other studies. Can you explain it to me?
Okay, Mahta.
Yes, first I have to mention something. The idea of naming the placebo group as sham was directly mentioned by Professor Dahmer himself. He just insisted using the word sham instead of placebo because we were not using drugs or any medicament, because that's why they used the word sham. For low power laser, something is very important. I did mention at the end of the discussion. Low level lasers are very, very effective when the effects are accumulated. We have to have multiple treatment sessions, and for other treatments, for example, the treatment low level laser therapy on the knees, for example, any other thing for chronic pain on the knees or ankle, they use it for repeated sessions. with at least 2 days time lapse between the sessions, and the accumulated energy is important here. That's why in many of the studies done in this regard in dentistry, especially after endodontic treatment, they all did the low-level laser only in one session. Maybe it could be of help for future studies if you do this for just repeated sessions to see the real results. Because I do think and I do believe that one session of low-level laser will not have that much biological consequences that we really need and expect. Repeated sessions are necessary. But this was the clinical situation. We couldn't just ask the patient to come back during the coming 2 weeks, every 2 days, just to repeat the irradiation. It was not practical. It was not also set in other studies. Every study was done in single session. So this is my real comment for the future studies. If you want to design, everybody here want to design the same study, this would be of help. If you do this for repeated sessions, it would be great help. And this is one of the reasons for conflicting results reported by different studies. This is one of the reasons.
Okay, if you use, what do you think, if you use this more than 15 seconds, I mean for 30 seconds, what kind of results would you have? Do you have a different results on the positive aspect?
I don't think, as much as I know, just increasing the time in one session may not be that much effective, but in repeated sessions, I think you give the tissue some rest time, and you just give time for this biostimulation to take effect. After 2 days, again, you repeat, the dosages are accumulated, and that is the exact mechanism of being low-level laser being effective.
Okay, did you perform this 15-second for mesial and 15-second for distal?
On
or
distal, yes, on each tooth. We have different strategies in different studies, but in this study, we just did this 15-second on each root, mesial and distal separately. But in different studies, if you have seen, they have irradiated from some of them from both buccal and lingual. Some of them just put the probe in direct contact with the tissue. Many different strategies have been used, and this is again another problem with the results not being in the same line. I think there are different methodologies.
The parameters were not standardized in this kind of studies. I read them all. Yes, you're right.
What about the size of the tip? Because you asked also about the size of the tip. Has it any effect? Do we have different one?
Are you asking me or Burçin?
I'm asking you, Mahta.
Again, would you please repeat that? I didn't get that.
I'm asking about the size of the tip of the diode, or of the tip of the probe that you shoot laser out of it. Is there any difference between the studies about the size of that?
The tip size in different devices are different, but all of them have one thing in common, that the tip size with low-level laser is much larger than the high-power lasers. In high-power lasers, we want a very small area, just the laser to be focused in one point. But here we don't need the power that much. We don't need power at all, actually. So the tips of these low-level lasers are usually wide, something between 0.7 millimeters to even 10 millimeters. And some of the devices that they don't have an extra dedicated low-power laser tip, they recommend using the bleaching tip, which is very similar to that one with the wide width.
Okay, thank you very much. But before we go further, there is another question from Professor Virash. Virash, please turn on your microphone and go ahead.
I'm not purposely turning off my video because I'm getting a haircut done.
Virash, can you hear me? Please go ahead if you like.
You can hear me now? Hello?
Yes, we
Virash
can hear.
already
Yes, you are on the air, Visha. We have your voice.
Okay.
hear you.
I am not switching on my video because
Oh
I'm
my
getting a
God, that's beautiful. That's beautiful, Virash.
Oh, video got on. Sorry. Okay,
No,
now
don't be sorry.
my-
Please go ahead. Please go ahead. Good,
Okay.
good.
my one no video, please don't ask me to switch on the video.
But the video is
Okay.
good.
My question is that mandibular first molars, mesial canals are known to be very notorious in canal configurations, right? Confluencing canals and different types of canal configurations can be. How did you handle that while applying lasers there?
Okay, Mahta, asking the question is about the mesial canals and its configuration.
Yes, I had some problem with hearing the question. I had some problem with the connection.
The question was about the mesial canal, mesial canal and the configuration of the mesial canal. Virash, can you repeat your question again, please?
Okay, I'll repeat with the video on. The question, the question is that how did you mandibular molars mesial canals are known to be very notorious with the canal configurations, right? So how did you, were there any trifurcations, bifurcations, or different type of canal configurations? If present, how did you handle and how did you rule out?
So you're speaking about, for example, about the third mesiobuccal canal?
Third mesiobuccal canal or the confluencing canals and, single portal, two portals of exit, two portals, single portal of
the
exit.
apical delta, different
Yes.
anatomy, something like that, Mahta.
Yes.
I think I got him. I just think I understand what he said. I think we had to emphasize that if the patient didn't receive a neat and clean retreatment, he would be excluded. This is a must. And a standard retreatment with success reaching the apical area, cleaning or the ramifications, the isthmi, everything, if was done clearly and all the canals were just instrumented and cleaned to the full working length without any complication, that patient would just receive the laser or not, he would be in the sham group. I think we should have emphasized this. If, for example, if during retreatment any broken instrument happened or all the canals were not negotiated to full working length, this is crystal clear that the standard retreatment was not done due to any problem. And so the patient must have been excluded.
Okay, great. Thank you very much. And I'm happy actually today that we have Professor Kim, the president of APEC, and Professor Sanjay Miglani, the dean and the head of the educational committee with us. So for you guys to have a break, I'm going to ask Sanjay to have some comments, and then we have a video from our sponsor, and then we go back to you, Burjan. Sanjay, please.
Hello, everyone. It's such a pleasure to be on this platform, and thanks, Dr. Nikufar, for this wonderful work. And my appreciation to the presenter and the author. Please go ahead. It's a wonderful program, and I will not disturb you for a long time.
I know you also have a lot of idea about the laser and post-operative pain, and we are waiting for your comments somewhere in the discussion as well. Thank you very much, Sanjay. And when Professor Kim is ready, we are happy to have his comments as well. Hello, Professor Kim. Thank you very much for joining us. And it is a great pleasure having you as our president. Professor Kim, please.
Thank you very much for calling again. I just want to see what is going on in your platform. So as Sanjay said, I always enjoy your program, and then it's very nice platform for all the APEC member societies to review one specific journal with the authors. So once again, thank you very much for this good chance, making this good chance from Dr. Nikufar.
Thank you very much for your support
enjoy
and for letting me do this in our educational committee.
Thank you. Yeah, we will enjoy this.
And still, I know that Professor Kim, you also have a lot of idea about the mechanical preparation and use of laser and other stuff. So if you have any comments so far, please go ahead.
Oh, actually, about this the small tool using the laser or other specific devices, especially for the laser. Actually, I don't use it, and then I don't really believe the real effect from the laser on the root canal treatment. Someone and also some colleagues in Korea, I know some guys believe in the real effect from laser, but I myself does not believe it, because the sodium hypochlorite and sonic activation or ultrasonic activation may do what we need in our clinical situation. That is quite enough. So yeah, I'm not.
That is actually my first question from the first author. And I asked her why you decide to do this study, because sometimes even the post-operative pain and also we can control everything maybe inside the canal rather than outside. But I'm sure Mahta is going to give some answer to your comment. Mahta, please go ahead.
I need to say something. This may not be very pleasant for some of the people here, but
the aim of this session is to discuss frankly with each other. There is no shame or there is nothing like that. We want to discuss frankly. This is science. Don't worry.
Let me tell you something. When they introduced laser to dentistry, the companies, I do believe that they started looking for different ways of including this laser by force in different different fields of dentistry. When it came to endodontics, they just looked for, okay, how can we use it in endodontics? They started from root canal disinfection. They ended up with low power laser and pain reduction. If you ask me, is it worth buying a laser just as an endodontist, just for pain relief? I wouldn't recommend that. If you love laser, you could buy it, you could use it for root canal disinfection. Is it more powerful than the routine techniques of root canal disinfection? This is still my question. It may be not. Just, I recommend the strips technique. If we have time, we would talk about this later. It is out of the scope of this speech, but I'm at your service.
Okay, that's another question, I think, because Professor Kim already mentioned that sometimes we can control pain by just sodium hypochlorite or simple procedure or even cost-effective procedure. So let's ask this question from all of the participants if they have any idea. Is it really cost-effective for an endodontist to buy a very sophisticated laser machine? Is it really necessary or not?
I want to add something.
Okay, Ilke, please go ahead.
Especially, I want to speak something about diode laser because it's a cheaper laser compared to the other ones, area laser or somewhat. But even it was reported that low-level laser therapy has not excessive effect on external surface temperature rise. And you know, this temperature rise over 10 degrees may harm the periodontal tissues, you know, and it was also reported that previously, in very recent articles, in particular, diode laser causes higher temperature rise compared to the other types of the lasers. Am I right? Diode laser causes some very higher temperature rise. And I think considering this issue, I think it should be more data about its warming effect, the warming effect of the lasers, and also the risks of it over its benefits should be weighed. Maybe the use of lasers can be limited with only laser activated irrigation in endodontics, because in here some irrigation solutions maybe decreases the temperature rise. It helps to decrease the temperature rises, because when we contact directly to the mucosa, I think it can be harmful. It's my opinion.
Can I say
Okay,
something
Mahta,
about
what
that,
do you
Professor
think?
Nakfar? Yes. Do I have time to explain this before the clip
Yes,
is
please,
on, or
please.
I have to wait? Okay.
No, no, please.
I have to tell you something. Lasers in dentistry are divided into two parts: low-level lasers and high-power lasers. In high-power lasers, both the two most important lasers that are being currently used are the erbium family and diode lasers. Erbium family, if you put them aside as the most expensive available lasers now, we put them aside. As you said, diode lasers are the cheapest and most available lasers. With diode lasers, we can have two functions: low level or high power. With high power, we can expect tissue cutting, we can expect coagulation, we can expect for example, root canal disinfection. But this is something that creates heat, and heat is something important. It has been the subject of many studies. For the more the laser, high power laser, is absorbed in the surface, the less will be the temperature rise in underlying tissues. But here we are talking about the low level lasers. Low level lasers are they don't produce heat. They don't work by heat production. The mechanism of action is molecular. They act in the cellular level. They act on cell mitochondria. They may elevate everything in cellular level. That's why they may cause tissue healing, nerve regeneration, fibrosis. Whenever we need collagen synthesis, these lasers may be of help. They are low level because the power is less than 0.5 watts. This is nothing. It does not create any heat. It doesn't work by means of heat production. That's why we are not worried about just their application if we think about just temperature rising in the tissues. If you have experienced yourself the low level laser therapy, when the probe is applied on your skin or mucosa everywhere, if it is attached, you may feel a little warmth on your skin. That's all. The mechanism are just in tissue levels, and that's why the biostimulation and biomodulation is done. So heat is not a concern in low-level laser therapy.
Okay, thank you very much. I think Sanjay has got something to say. Sanjay, please.
Yes, what you asked, whether it is worth to invest in a laser for endodontic procedure. I think the lasers in endodontics are still evolving. And if you see theoretically, it makes a lot of sense to use laser, especially low power laser in endodontics. So I think with time, we might have better tips, we might have better lasers, and I personally feel that it will make a lot of sense to invest in science and newer equipment.
Okay, that's I think a comment that's we can agree with that without any discussion, obviously. So that is a very important comment, I believe. Miguel, do you want to add something? No, yes? If yes, you can speak. No, okay, thank you very much.
Thank you for the opportunity, Professor Nekofar, but I'm just listening to you. I'm not really prepared in this topic.
Okay,
but,
good to join us. Thank you very much.
For this study club is amazing. I like to listen to you. Thank you very much.
Okay, thanks. Thank you very much for joining us. Thank you very much. Okay, Zohre, please go ahead. We are going to have 1 minute break by watching our sponsor. Okay, Burçin, please go ahead.
Actually, I have another question to Dr.
Yes,
Mahta.
please.
Dr. Mahta, normally in
Mahta, are you alive? Are you still surviving? Okay, Burçin, go ahead.
Yes.
Actually, in my clinic routine, I always use activation system for irrigation. In this case, you didn't use any activation system. Is there any special reason for it? I mean, did you think that it will affect your results in positive or negative way?
If we used it, it would be of help, but we didn't use it. It didn't affect the results. Actually, I don't know. We could use this we could use any, for example, ultrasonic activation or other devices, but we didn't use. We were trying to be close to the normal. I mean, not normal, the routine which is being done by most of the colleagues, but this would be very good, but we didn't do that. It didn't affect the results, I think.
For me, for my clinic routine, I think it's a gold standard for us, the activating the irrigation system. So if I did this same thing, I would prefer to add an activation of the irrigation, but I understand your reasons, okay?
Yeah, in terms of methodology, Burçin, I think the most important thing is to be consistent. As far as we are consistent in both groups, I mean, somehow you can standardize your methodology yourself based on your idea. It doesn't matter to reduce some of them. And sometimes for something like calcium hydroxide and for activating of irrigation, they may have some sort of adverse effect as well on post-operative pain. And because we don't have any idea about them, because nobody evaluates the effect of activating sodium hypochlorite on post-operative pain, therefore, sometimes you may decide not to use this type of enhancement because they may have some co-funding effect on the result. Somehow I'm cheating and I'm helping Mahta for that, but because this is the science that I want actually to emphasize that. If something is gold standard, yes, I agree with you. But activating sodium hypochlorite may push sodium hypochlorite and may push free radicals outside the root canal system and may produce more susceptibility to post-operative pain. Therefore, we need to be careful about all of these things and control everything in a consistent and very, very similar groups. That can be the result. Maybe Mahta can add it in the discussion in the second publication. Okay, go ahead.
I think everything down. I have filled something big like this. Every comments are being written here.
Good. That is the goal of this club. Okay.
For the post-treatment pain, the authors, each patient was given a home questionnaire and second visit was scheduled 1 week later. Postoperative pain levels was scored at 4, 8, 12, and 24 hours and 2, 3, and 7 days after treatment. The patients were contacted by phone on specific hours and days to remind them to record their pain level. 10 tablets of 500 milligram acetaminophen were received. Patients were asked to record consumption of analgesic on the questionnaire. What about the statistics? The author used SPSS software program with the 95% confidence interval. Independent sample t-test was used for normally distributed homogeneous variables, while Mann-Whitney U-test was used for non-normally distributed non-homogeneous data. Nominal variables were analyzed by chi-square tests. And our results. The 36 patients conducted in the study and all of them attended the follow-up sessions. 20 was female and 16 was male patients. The mean age of participants was 43.5 years, and it was ranging from 28 to 59. The number of unscheduled appointments was same for each group. It was 3. And none of the patients reported postoperative swelling, sinus tract, palpation pain, and none of them reported taking analgesics. The mean of was before and after treatment in 2 study arms are shown in the table. According to the results, in LLT group, 24 hours after retreatment and 48 hours after retreatment, the patients reported most intense postoperative pain. In no LLT group, in sham group, patients reported most intense pain 4 hours and 24 hours after retreatment. 2-by-2 comparison of mean treatment pain intensity at the various evaluation times in both study arms shown in the table. And according to the results, there was a significant difference between the groups in 4 hours after retreatment in the favor of LLT group. After 4 hours after retreatment, LLT group significantly reduced the postoperative pain when compared with sham group. In both groups, post-treatment pain followed the decreasing pattern after 48 hours post-treatment, and the pain levels remained similar up to day 7 after treatment.
Burçin, can I ask you to go to the previous slides, please? The previous one?
Okay.
Oh, yes, in this one. I have a concern always about the studies that they evaluate post-operative pain or even pain during the treatment or whatever like that. And my question is very general, not just for this study. My question, Mahta, is about the clinical significance versus statistical significance. Mm-hmm. Because in your study, by looking at this table, I can see after 24 hours after retreatment, the mean value of pain according to VAS is 0.22, which is almost less than 1, I believe. And less than 1 for me is almost, I would say that, not a clinically significant pain. And obviously when it goes to 4 hours after retreatment, it becomes like 0.78, or even after 24 hours in sham group, it becomes 0.72. Comparing these to each other, however, it shows that there is a significant difference between 0.22 and 0.72, but both of them are less than 1, I believe. And in that case, the question is there any clinical significance between these two, even if there is a statistical significance? Can you help me with that?
I do believe that, yes, I understand what you say, and you're correct. Exactly, you're saying the right thing. I think the clinical significance is directly dependent on patient. This is a personal issue for every patient. One patient may feel the pain very intense. The same level of pain may not be that much intense for another patient. So clinical significance, I think, is something that cannot be evaluated. It cannot be compared between the patients. For one patient, no pain is expected. Even a little pain is very significant for him or her, but for another patient, this may not be the issue. So that's why we are looking for statistical significance, but clinical significance is very important. It does exist, it does matter, but it has nothing, we can't do anything about it, I think.
So let me change the way that I ask you my question, and I ask my colleagues also to help me for that. Because I can see Professor Kazandag with me, my friend, Meric. Meric, please, you also help me for that question as well, and others. The question is, when we are using a quantitative way of pain measurement, like VAS, that means we try to quantify perception, pain is a perception. It's not a simple thing to measure. Obviously, we use VAS just to make it possible to compare the groups with each other. Okay, but if we need to tell the statistician that pain less than 1 is not a pain. Pain less than 1 for me is not a pain. But you may say that, okay, statistically, there is a difference between 0.2 and 0.7. Agree. But in reality, speaking about the patient, do they need painkiller? The answer is no. The answer is no. Maybe you can make it simpler. Say that severe pain comparing to moderate pain, comparing to no pain, something like that. So therefore, it comes to this level. Let's say speaking about, for example, plaque control for oral hygiene. Speaking about the plaque control, if the patient has 20% of his mouth still plaque on the surface of the tooth, we may say that, okay, this hasn't got any clinical significance on the periodontitis, comparing to 30% surfaces. But when it goes to more than 50%, it becomes clinically significant. So we give the statistician a border for evaluation of significance. That is very important methodologically, I believe. So let's others also help me or help you. Let's see what others think about that. Viresh, Marich, Professor Kim, others, please help me.
If I may, in a simple.
Yes, please. Yes, please.
In the simplest of the manner, I think what you are trying to say is the clinical relevance of this result. The differences between the time periods, mean whatever is the difference between the time periods, what is the clinical relevance of that? Because it is very negligible when it comes to a clinical setup.
Exactly. That is the question. So let's say if you prescribe analgesic or a painkiller to your patient for just a pain, that patient said, I have a pain, and if it goes from 0 to 10, my pain is just 1. You may say that, okay, do you need a painkiller? And that can be a way of the measurement of the perception of the pain. Or we can ask them, has it got any effect on your quality of life after the treatment or not? Something like that. Okay, I agree with that the pain can be very, very harmful for a patient. But if it is harmful, they should say that they have 5 or 6, not 1. Marriage, what do you think?
I think period of the pain is important as well.
Can you repeat, please? It wasn't clear. Can you repeat, please?
Yes. I think duration of the pain is important as well. So if it is temporary, something temporary, let's say a couple of hours, it doesn't matter. But if it is something continuing, it is still a pain, I think, although he doesn't need any painkiller. So if he doesn't feel that everything is okay, I think there is a problem. And there is something to talk on about the reason.
Okay, very good point. I think it's in favor of Mahta, because when we look at the LLT group, we can see that in LLT group, the level of pain, even immediately after retreatment until 7 days after that, is almost similar. But when it goes to sham group, we can see that from 0 to then it comes to, and it increases. So if in that case, we may have a graph and compare the graph with each other, Mahta, for the next publication of yours. What do you think, Mahta, yourself?
I do believe you're right. Exactly, you're right.
But marriage helps you. Marriage helps you. You or her.
Yes. She mentioned a very important. She mentioned a very important thing about the pain duration.
Okay. Yes, you're right. You're right. Thank you very much, marriage. That was wonderful. Very good. I didn't realize that important things, because yes, if I have pain just for 1 hour, I may ignore it. But if I have pain for 2 days, even with a level of 1, still this is nagging. Good point. Thank you very much.
If I had this in my mind, I would have mentioned it in the discussion. This is a something
Wonderful.
very prizeful to talk about. Thank you, Mary. Thank you.
You are my star, Merit. Thank you very much. Which carry on. Actually, you are Mahta's star, not me. But don't worry, I agree. Okay, Burich, we are ready.
Can I go? Okay. The hypothesis, the null hypothesis of the author was there is no difference between the groups in postoperative pain intensity. However, LLT group had shown a better results after 4-hour treatment. So the null hypothesis was rejected according to the results. So in order to understand the mechanism of LLT, first of all, we have an idea about the etiology of postoperative pain. There are several etiologies of postoperative pain. These are mechanical factors like over-instrumentation, chemical factors like intracanal medicaments or sealers, some microbiological factors. These factors may release of many inflammatory mediators. These are prostaglandins, leukotrienes, bradykinin, platelet activating factor, and substance P. All these mediators stimulate nociceptors or sensitize them. And then a periapical inflammation leads to vascular dilation and increased permeability. And as a consequence, the edema or increased intestinal tissue response will be occur. So this is the mechanism. Today, we have several methods to control the pain. We already talked about them, the analgesics, narcotics, antihistaminics, but today LLT is gaining popularity because all these agents has some side effects, and we are trying to find the non-pharmaceutical agents. Well, LLT is one of them. Photobiomodulation by means of LLT is a form of phototherapy designed to apply low levels of red and near infrared light with wavelengths in the region of 390 to 10,016 nanometer with a power lower than 500 milliwatt and an energy density lower than 670 milliwatt per centimeter square. These lasers are non-toxic, non-allergic, and easy to use. LLT acts via a photobiostimulation effect, that is the induction of photoreaction in cells via light stimulation. The therapeutic approach for LLT follow 3 principles. The first of them, minimizing inflammation and edema in chronic disorders. The second one is wound healing, and the last one is treatment of neurological disorders and neurological pain. LLT has been used in several purposes in dentistry. These are reduction of dentin hypersensitivity, acceleration of wound healing, healing of periapical lesion, healing of damaged nerves and treatment of paresthesia, reduction of the gag reflex during root canal treatment, or radiology.
Oh, can you go back to the previous one? Reduction of the gag reflex is very nice to hear that. And thank you very much for this slide. That is very informative. Thank you very much. This is beautiful.
You're welcome. You're welcome.
So can you tell us about the gag reflex, how it can affect on the gag reflex?
Dr. Mahta will tell us, I think.
Okay, Mahta, tell us something. Gag reflex, how? Laser on gag reflex. Because gag reflex can be a nightmare sometimes in our patients.
We have to go back to the mechanism of gag reflex. It is the nerves being over responsive. So if we could downregulate the nerve response, it can be of help. You know that even I didn't mention it here. Low-level laser can be even used for snoring. Treat the snoring.
Arash, this is good for you then. This is good for you.
You know why?
I don't snore.
I'm just joking. I'm just joking.
Maybe you're right also.
But by the way, you become very beautiful after this haircut. You become very beautiful.
No comments.
You know,
we'll talk later.
I have understood. I have understood that low-level laser is used for everything.
Even for haircuts.
Even for haircut. I
LLB.
just wanted to say that.
Okay, thank you very much. So gag reflex, that was amazing. There are some very, very interesting issues today we heard. Okay, great.
No,
Okay.
if I may ask,
Yes,
if I
please.
may ask Dr. Mehta, very sorry, but I really want to mean it's a very interesting point that gag reflex can be controlled by it, because there are some patients who will have a gag reflex even on application of rubber dam. You know,
Yes.
if you place a film, definitely they will have a gag reflex, but some people have gag reflex also on the application of rubber. How do we control that? Maybe it is off the topic. I am not very sure.
This is not.
Do we need
This is not
some
a
more
one
sessions?
session treatment.
Yeah, Mahta.
I just.
Yes, that's it.
This is
Okay,
not a
please.
one-session treatment. This is not a one-session treatment. It requires repeated sessions, at least for 2 weeks, just to be effective. This is some kind of nerve biostimulation. I think that nowadays, if you go to a laser man, a really specified laser man, if you go to him or her, if you complain of anything, the first thing that they would offer you is low-level laser for everything. I just said it is even useful for snoring. You know, it just degenerates the collagen type 4 in the palate, and the new fibers or collagen are aggregated in a way that they just elevate the soft palate to reduce snoring. This is a mechanism. It is very interesting. The same thing can be done for gag. Even, you know, the patients that have some problems with their inferior alveolar nerve after just tooth surgery or anything, if something happens to the nerve, one of the treatments, actually the only treatment right now is low-level laser. They expect that the nerve regenerate and just join together, or even paresthesia or dysesthesia can disappear in this way.
That's great. That's really good. Thank you very much, Mahta. And I'm very happy that today we have the president of APEC and we have the dean of the educational committee and a lot of president of endodontic societies from the APEC members. And we have Professor Al-Hawaizi from Iraq, and he's the president of the Endodontic Society, Iraq Endodontic Society. Professor Al-Hawaizi, do you want to have some comment for us?
Hello, good afternoon.
Hello, Professor.
Oh, I'm very happy to be here. I really am very flattered with these events that you're organizing, and I congratulate you about these events, and thank you very much.
Thank you very much, Professor Al-Hawaizi. Do you use laser in your daily practice? Because I know you are a very, very, I would say, hardworking practitioner in dentistry, and your practice is not limited to endodontics, as far as I know. Do you think having a laser in a general practice is necessary, or even in endodontics, or not? As Mahta believes it is important to have a kit of at least a laser machine in our armamentarium. What do you think, Professor?
Well, really, clinically speaking, we use the diode laser for, you know, gingivectomies and these things. Regarding endodontics, we don't use it much. But research-wise, we're using quite a lot of laser. A month ago, I had one of my MSc students who finished, and she made quite a good research regarding diode laser. You know, we all know that diode laser doesn't work with water as in irrigation, you know, agitation of irrigants. But she used it with EDTA, and surprisingly, the SEM picture was wonderful. And by the way, the SEM was done in Tehran, near you.
All right.
Well, they were very, very nice pictures, and it was very, very astonishing to hear or to see that diode has such a good effect on the smear layer, and it removed it just as good as erbium laser with EDTA. So this is really something to me is quite remarkable.
Oh, that's interesting. Thank you very much for sharing it with us. Thank you very much, Professor Hawazi, and thanks for your support and being with us. Okay, we are ready now to go back, but before that, Zohra is going to show us some video. Zohra, we cannot see that. Okay, Burçin, please go ahead.
Okay, I'm sharing my screen now. Yes. Many clinical trials proved that the effectiveness of LLLT on endodontic pain after initial root canal treatment and the pain control mechanism of laser irradiation are attributed to the reduction of inflammatory prostaglandin, interleukin-1 beta and TNF-alpha, reduction of inflammatory processes, inhibition of firing nociceptors, increasing lymphatic drainage, increasing histamine release, increased production of inhibitory prostaglandins, inhibiting the synthesis of pro-inflammatory factors and neurotransmitters, increased level of immunoglobulins and lymphokines, increased production of beta endorphin and encephalin, and elevated level of adenocorticotropin hormone. Moreover, LLLT enhanced the elimination of pain-generating substances such as substance P, histamine and dopamine, and induces anti-inflammatory effects by inhibiting the cyclooxygenase 2 pathway. And also it increases the lymphatic drainage and affect the permeability of the cell membrane to calcium, sodium, and potassium ions. All those things show that the pain relieving mechanism of LLLT and more rapid periradicular repair might be anticipated following root canal treatment or retreatment cases. So there are several pioneer studies about LLLT in the literature. Chrysler et al. Used LLLT in endodontic surgery by using 819 nanometer lasers. Nazari et al. Used LLLT in root canal treatment of teeth with vital pulps and symptomatic irreversible pulpitis with 808 nanometer diode lasers. Arslan et al. Used diode lasers, 970 nanometer diode lasers, on the root canal retreatment of mandibular molar teeth with periapical lesions. Dona Yıldız and Aslan used 970 nanometer laser. On the other hand, Lopez used 880 nanometer lasers on the root canal treatment of teeth with necrotic pulps and symptomatic apical periodontitis. And Nabi et al. Used 164 nanometer diode laser after single visit root canal treatment in the combination with ibuprofen. In the present clinical study, the effect of LLLT with 980 nanometer diode laser on pain after root canal retreatment was evaluated. The radiation diameters were different. So the power of the study is about the standardization. The condition of the teeth was standardized to minimize the effect of confounders. The patients were standardized in the terms of analgesic intake before and after treatment. Location of the tooth, quadrant, and presence of periapical radiology or radiographs were also standardized. Root canal retreatment was performed in one session, and they didn't use calcium hydroxide. These were the power of the standardization of the study. By the way, I would like to ask the limitation of the study to the Mahta, because there is no paragraph in the literature, so I'm really wondering about the limitations. Could you explain me about your limitations? What would you change if you have a chance to redo this study, Mahta?
First of all, the greatest limitation was the start of the pandemic. We lost a lot of patients, you know. Exactly when we started the study, it was a thesis, undergraduate thesis by my undergraduate student. We lost a lot of patients. We were under lockdown, many problems we faced. But the other things that if I could go back, I would correct. I would mention each and everything that might cause a question in each of the colleagues' minds. For example, I would mention something that in each case, if something happened, we excluded the patient, how we did the treatment exactly, you know. I would do something that reduces the question marks in your mind, actually. This is not a shortcoming, but I would make it more complete if I had just chance to go back, and that's all. I wouldn't change anything else.
Okay, perfect. So from the beginning,
let me add something for the general limitations of the clinical trials. Obviously, loss of the follow-up is the most important thing. And whoever of us who is brave enough to run a clinical trial rather than a laboratory-based study must be really admired. And we always have problems in terms of close monitoring of our patients during a clinical trial. Even a laboratory study during the pandemic was a nightmare. But running such a study, Mahta, really was wonderful. Thank you very much.
Thank you for saying that. Thank you.
Okay, Burçin, please.
Okay, we have been talking about two important previous studies that was focused on the effect of LLLT on post-treatment pain after root canal retreatment. One of them was belonged to Aslan et al. They evaluated the effect of low-level laser therapy on postoperative pain after root canal retreatment. This study is very similar to our study now. And the difference is that they performed two-visited root canal retreatment and they performed calcium hydroxide. So we believe that calcium hydroxide also affect their results. They reported less pain after two-visit root canal retreatment. They found LLLT a beneficial tool for reducing pain. The other important study on this aspect was
don't go further. I have a question.
Okay.
Mahta, according to the, I would say, consensus of endodontics and endodontists, and even when we look at the textbook, we can find it that is written in the textbook these days about the comparing one visit to 2 visits for primary endodontic treatment. I think nobody discussed with anybody to say that I want to finish my treatment in 1 visit. But when it goes to the secondary or retreatment, there are some issues and some discussion about, are we allowed to do that in 2 visits, or should we, are we allowed to do that in 1 visit, or should we do that in 2 visits? And when we look at this Hakan study, we can find it out. They did that in 2 visits because it's like a gold standard for retreatment. But in your study, you did that just in 1 visit. And for retreatment, sometimes there is I'm not saying this is contraindicated, but there is some concern about not doing it in 1 visit. How do you justify that for the ethical approval or even for publication?
I have to mention that in this regard, doing a double visit or actually multiple visit retreatment or single visit retreatment, there is a dilemma. Still, there is a dilemma. But according to the textbooks, the current textbook, actually, the English Endodontics and Pathways of the Pulp, both of them, the latest edition, the only contraindication of single session root canal treatment is when you cannot dry the canal completely, or any kind of drainage or oozing is present in the canal. This is the only case that we consider as a contraindication to single visit treatment. Actually, there are some studies indicating that calcium hydroxide between appointments can reduce the post-treatment pain. On the other hand, there are many studies that say that even calcium hydroxide can just cause help some bacteria, some other bacteria to grow. This is a concept, I think, when there is a dilemma, and there are many studies in favor of both ways, both concepts. Each and every person can develop a concept. This is a self-concept based on the evidence-based practice. Evidences are still even in this regard. And I myself believe that if we could finish the treatment in a single session, it would be beneficial for both the patient and the clinician. Just we have to make sure that every disinfection protocol has been done in 1 session. If we can assure this, I think that calcium hydroxide has nothing to do more. I do believe that if we can do the, for example, great irrigation protocols or irrigation solutions, or even this laser, we can assure that a single session is enough. You know, some lasers, diode lasers, can disinfect the canal just when you insert the tip of the fiber inside the canal just before the obturation. When everything is ready for obturation, you can do this laser disinfection by means of diode laser. Or if you want to use more powerful laser, something like the Erbium family, you can do the laser assisted irrigation, the newest actually technique being the pips and sweeps that can even eradicate the smear layer to great extent, and even it cleans the dentinal tubules. So if we can assure we can have this kind of disinfection protocols, we can just be sure that single session is enough. This is my belief.
Okay, thank you very much, Burçin. I think that was completely, and that was enough. She covers everything. She covers everything.
Okay, perfect.
Okay, please go ahead.
The other study, the other famous study, belongs to Esnaashari et al. They also used LLT in the management of post-endodontic retreatment pain, but in this case, that used posterior teeth. I mean both maxillary and mandibulary, first and second molars. It was a single visit, not a double visit. They didn't use calcium hydroxide, and they stated that LLT had minimal effects on post-treatment pain associated with single visit root canal retreatment. So it's generally about radiation diameters, parameters. So I will talk also about them in my next slide. So do you have any question about it?
No, I'm fine. What about others? If there is any question, please go ahead. Any comment, any question? Okay, Burçin, please.
Okay, what about results of the present study? In the present study, LLT had better results at the end of the 4-hour treatment. So they found positive effects on reducing postoperative pain. So could different radiation parameters affect their results? Because there are controversial results here. In Aslan et al. Study, they used 907 nanometer diode laser, which was irradiated for 30 seconds with power density of 2.86 volt per centimeter square, using a 200 millimeter optical fire and a bleaching application tip with a distance of 10 millimeter to the tissue, and they found that post-treatment pain could be reduced. But in Esnaashari et al. Study, they used 880 nanometer diode laser with fiber diameter 600 micrometer and a dose of 17 joule per centimeter square for 80 seconds were applied, and no significant change in the level of post-treatment pain was reported. And also the application of radiation of the mucosa plates is also important. Esnaashari et al. Applied buccal and lingual mucosa overlying the apices of the targeted tooth, while Aslan et al. Irradiated the mucosa from the mesial and distal root apices. These are the main differences between these two common studies. So in the present study, what about the present study? In the present study, a single dose was applied and 980 nanometer diode laser set at 6.89 volt per centimeter square energy density, 0.5 volt power, and a tip diameter of 10 millimeter was applied for 15 seconds to the mesial and distal apices of the tooth from the buccal side, with the tip of the laser handpiece held at a distance of approximately 10 millimeter from the tissue, and they found that postoperative pain was reduced only after 4 hours after single visit root canal retreatment of mandibular molar teeth. So, what is the reason of these controversial results? According to the authors, the radiation parameters could be the effects of these controversial results. And according to the Jenkins and Carroll study, treatment parameters including beam spot size at target, irradiance at target, exposure duration, number of points irradiated, area irradiated, number and frequency of treatment sessions have measured impacts on the amount of delivered energy and thus the clinical results. So this will explain these controversial results of these 3 studies. Yes, within the limitation of this study, low-level laser therapy with a 980 nanometer diode reduced the intensity of post-treatment pain only after 4 hours after single visit root canal retreatment of mandibular molars. It was a perfect study for me. It was a big enjoy for me to read them step by step, word by word. Thank you, Mahta, for your
Thank you very much, Burçin. You did a very, very great job. Honestly, I personally enjoyed. I personally read this article many times, but with your presentation, it was different. Honestly, it was different. Thank you very much.
Professor Nekufa, for me, who wrote the article, it was also different.
Yes, that was beautiful.
That
was
beautiful.
I'm honored actually to say that I'm also second affiliated to Bahçeşehir University. So I'm working with Burçin and other colleagues over there. And that was a great day. Thank you very much indeed. Thank you very much. So is there any comment, any question? We still have something else to do. Is there any question? We still have around 15 minutes to finish the session. Is there any comment, any question from anybody? Okay, before we go to the last part, I'm going to say a big thanks to both of you. I mean, both of you, Burçin and Mahta, and other actually authors of this fantastic article. As I already mentioned, this is sometimes very, very easy to criticize something like that, but it's not very easy to run such a study. So the brave one is the one who run this study. For us as the appraiser, as the critical appraisal, is always very easy. It's very similar when we watch a film and we criticize that film, and obviously the producer may say that that was very difficult to make a film, and they spend a lot of time, a lot of money to do that. And then at the end, just in 1 minute, we may say that, okay, that's a problem in that particular sessions. That was wonderful. And the reason that we discuss frankly with each other is just because we want to facilitate better and future studies. That is the goal. We want to have good evidence from you guys as scientists, as young scientists, obviously, to give us information for our future generation. That is the goal of this club. Thank you very much indeed. And I'm sure Mahta has something else to add up, and we still have around 10 minutes for Mahta if she wants actually to end up the session. So before that, I ask Zohra to give us something and to show us some video from our sponsor, and then we give the stage to Mahta to finish up the session. Zohra, please go ahead. Okay, Mahta, please.
Professor Nekufar, this was really an honor for me because Burçin, you did a great job. Thank you very much. You put too much effort in this. You read all the articles, and actually when you present something like this, I myself consider it as an honor. Thank you very much. Thank you very much. It was great. I really appreciate the time that you put into this. I just need to ask something from all my colleagues. Do you think is it necessary for me just to share my screen, just to wrap it up and talk about some, just as a good finish, to review the applications of laser in endodontics, to come to a conclusion at last?
Yes.
Should we
still have 11 minutes from now. You have 11 minutes. I will finish you at 11 minutes. So go.
I wouldn't take that much time. I just want to review the applications of laser in endodontics. That's all.
Okay, go please.
From left to right, the first application, which is usually done by diode lasers, is root canal disinfection. As I said, the fiber tip is inserted almost to the root, to the full working length, just before the obturation, when everything is complete and the canal is ready for obturation and dry. We just shoot the laser. We just count like this: 1001, 1002, 1003, and in a spiral direction, we just come out of the canal. This is enough for disinfection. Another application for laser is photodynamic therapy in endodontics. When we insert a photosensitizer inside the canal, these photosensitizers now can be metal and blue or nowadays something which is very heavily worked on is the curcumin. There are two main photosensitizers that are used as root canal disinfectants. They are inserted inside the canal, they are absorbed by the bacteria, and when the laser, the exact laser that is absorbed by this photosensitizer is shot, the bacteria are dead. Just the very same mechanism are used for treating the cancers. This does not include the bacterial resistance to any agent. So this is a very good idea of using laser. So first one is root canal disinfection. The other one is photodynamic therapy or antimicrobial photodynamic therapy. The last but not least is laser assisted irrigation. The first generation of laser assisted irrigation was done by the erbium chromium VSGG. Which just included inserting the laser tip inside the canal, but not to the full working length. In the presence of sodium hypochlorite in the root canals, we could expect just removing the smear layer and cleaning the canal surfaces. The newer generation is the sweeps, or which comes after PIPs. Sweeps just requires a different tip, which is stripped in the tip. And it does not necessitate just insertion the laser tip inside the canal, which have to hold the tip inside the chamber. That is enough, and the canal and chamber is flooded with sodium hypochlorite, and laser activates this hypochlorite. It can insert this hypochlorite to the working length, and again it removes the smear layer, and we can expect intratubular disinfection as well. This is the latest technique. These are not low power. This is high power laser, and low power laser is something else that is used for there's just pain control and other things that I just thought that it would be of help for my colleagues to share the data. That's all.
Thank you. Thank you very much, Mahta. We had a great time with you guys, all of you, and thank you very much for the support that we have received from all of you, and a very good discussion, very good and very informative session. And please accept my apology if I ask very harsh questions. Obviously, this is my job in this journal club, to ask this type of questions. And as I said, the goal is to increase this type of interaction, to increase our knowledge, and we learn from you guys. So I hope Professor Kim is still with us. Yes, I can see he is still with us. So I'm going to ask our president to finish the session. Professor Kim, if you are able, please. Yeah, I leave the sessions to you, and thank you very much for staying. I know in Korea, in Seoul, it is very late, but thank you very much for staying with us. Please close the session, you.
Yes, it's midnight in Korea, so
oh my God,
the end of this session. And always, as I told you before, it's very good platform you made for all the Asian Pacific area, the researcher and postgraduate students. Anyway, I will wait another chance next time. And then some of you may have my message from a few days ago. I wrote an email. We are trying to make another platform to change the clinical idea with some clinical cases, the endo cases, not from this kind of scientific journal. So we may meet at another chance to talk about our clinical technical idea. So we'll see you some other chance, and thank you very much. Hope you all stay safe. Thank you very much.
Thank you. Thank you very much, Professor Kim, and thank you very much, everybody. Let's put our hand together for Mahta and Burçin. Thank you very much indeed. Mahta and Burçin, thank you very much. Goodbye, everybody. Have a very good night and afternoon to all of us. And thank you very much, Professor Kim, for staying with us. Goodbye, and see you soon in 3 weeks in our Western Zone time that we discuss on Saturday. Thank you very much, and goodbye.
Thank you so much.
So much.
Thank you. Thank you.
Bye.
Bye-bye.
See you again.
Bye-bye.
Bye-bye.